council level.
Some of the speakers spoke about the potential to reduce costs, but what are the costs associated with this initiative, and where are we going to get them?
I'm going to turn over to one of the medical providers to talk a little bit about the costs in the system. I mean, part of the overall costs away, it's not so much from a city standpoint of reduction of costs. The city invests $18 million a year in our fire department. But when you think about it as a community, the costs associated with delivering health care and where we're trying to shift and relieve some of those cost burdens, it's outside of a high-cost system like an emergency room. The emergency room is geared up, the way I understand it, whenever I've been there, to take care of emergency issues. You have high-quality doctors, high-quality nurses. You have all the equipment in place to make sure that a person's life is saved the second that they walk through or that they're taken through those doors into the emergency room. That comes at a large cost. If those costs can stay focused on the individuals that really need it, and we're able to divert those who don't have emergency room related issues into other areas of care, then that alleviates the costs associated to the general public of paying through Medicaid and Medicare and other things that have to go to cover the costs of non-emergency visits today. So a lot of it's about diverting people out of an ER room that would be costly. Kathy, if you want to, did we get that right?
The city did a study last year and looked at the top 100 offenders in the community. If anybody wants to add to that, please jump in.
Users, not offenders.
Yeah. No, this was offenders.
Oh.
This was offenders. Looking at it was the law enforcement assisted diversion program. And so they took 100 offenders and they looked at their utilization of EMT services, hospital. Out of the 191 of them were frequent users of the emergency department. 1,100, there were 1,100 jail days for the same group, 590 arrests, 5,500 officer hours. And there was $4 million spent, 41,000 per person. And so the ER costs are huge in that. We're looking at people who are coming into the ER up to 100 times in a year. And again, people who are isolated and disenfranchised and have no one looking after them and no one to support them. So.
Is there any startup cost the city needs to come up with, or is that?
So the question that I'm working, or the resolution that Councilor Rivera is working on, is asking the council to endorse a study of and a development of a program that will actually identify the costs associated with starting up this program. At the end of the day, there will be costs associated with this program, but we're also wanting to look to the community providers, the foundations in this town that are focused on making sure that communities have access to high quality care. But there's no doubt in the long run that we are going to be able to reduce the costs associated with health care in our community. More importantly, we're going to raise the level of the quality of care that's given to every citizen.
Can Andres or someone explain? Okay, so we're talking about kind of a assessment like insurance, primary care doctor. Does that happen during that period when you're responding to a 911 call, or would you come back and deal with some of these things? Can you kind of explain how it would work?
Sure. So calls that come in through the 911 system right now are handled in one very specific way. You send emergency resources, and they work under emergency protocols. What we have done is we've identified the individuals who use at a disproportionate rate, and then we're scheduling visits with them at home. So this is these are scheduled, not emergency visits. As far as the costs, 18% of our gross domestic product right now is spent on healthcare. That's like 4 or 5 times what we spend on our entire defense budget. So it's an extremely expensive system, and it's very expensive in large part because, like Dr. Johnson mentioned, the lack of primary care, and it's really a reactionary model. So we're hoping that by even though there will be program costs associated, right now every single one of us, if we look at our checks, there are huge costs associated with healthcare, enormous costs that dwarf the cost of this program, but the potential of savings with a program, with a successful program, are enormous. So even though there are upfront costs associated with it, we are very certain that the benefits will outweigh the cost by a significant margin.
So so the idea is, there's a frequent user of the 911 EMT system, is to go back to those people and try to help them access.
I'll give you an
insurance.
example. So there's
Right.
a gentleman, an elderly gentleman who lives here in Santa Fe, who was calling 911 very frequently. We went to his house. He's got some alcohol dependence issues, and he's got a very serious cardiac history. He's on many medications. First of all, he was taking 3 times the amount of blood pressure medication he was supposed to be taking because 2 different doctors were prescribing. Second of all, he was only taking 3 times the amount of medication when he took any medication at all, because most of the time his pill bottles were empty. And the cost of taking that individual to the ER by an ambulance is significant. The cost of his disease process getting worse and worse because he's not compliant with the treatment plan is even larger. So we were able to work with the individual and first of all identify the medication issues with Kate from Southwest Care, with the pharmacist, and then communicate that information back to the patient's primary care physician, who's the one that made the changes. Obviously, we're not in the houses changing people's medication regimens. That's a doctor's role. So we were able to get him the correct medications, get him to become compliant, and even though he's still struggling with alcohol use, he's talking about going into a treatment program, but he hasn't called 911 since May. And before that, he had been calling 911 regularly. So, and what the cost of that service was minimal. I mean, there's not a lot of fancy equipment. There's not a ton of personnel. It's as I believe Jeff Thomas mentioned, it's about building a relationship with that patient. The relationship is what gets people to understand their issue and really become empowered to take care of their issues in a better way. So that's just one example of how it's a fairly small investment in prevention, and it has a huge downstream savings potential.
And I think you captured that, right? Well, your question is that this is not about modifying a 911 call at all. That's going to stay in place. If someone calls 911, our first responders are going to show up and they're going to transport them to the emergency room. This is about our first responders knowing who the high utilizers are, people who are calling 3, 4, 10, 15 times, focusing on those individuals and really trying to do something to say, what is the problem here that we can help you increase your access to a caregiver, and certainly to minimize your time in an emergency room.
And it sounds like y'all been doing some of this now, right? How long have y'all been doing some of this?
So, as Councilor Rivera indicated, this is an issue that Chief Litzenberg and Andres brought forward to us several months back, and at the direction of the city manager, he's allowed them to pilot a very small program where Andres and his peers have identified individuals and worked with them. About 25 people have come into this pilot project to allow over the last several months this intervention, this prevention program, where the firefighters were actually visiting with them. They were doing the medical reconciliation with the help of Southwest Cares. They were visiting with St. Vincent's doctors to understand what can we do to help them on the front side. They were doing those home assessments. There's an individual that I met last week with her son who has epilepsy, and she was a high user of 911 when she needed help with her son. And she explained that Andres and his team went in, and when they did a home assessment, she lives in a 2-story house, the hand railings on her stairs were loose. They got together, went to Home Depot, they rebuilt those hand railings because she has to carry her son up to the 2nd floor. They spent time with the other children in the house to talk to them about fire prevention because they all slept on the second floor. They did that type of basic assessment. But what really changed and what became that point of improving the quality of care is that Andres went to the school where the child goes to talk to them about how they're giving the medication to the child while he's in their care. And it was and they hadn't been giving it the right way. So he was able to coordinate the delivery of medicine at the school with the school professionals and at home. And when you ask her how many times have you called since that happened, it's gone to 0, right? So that's a basic example of what we can do to improve the quality of life of individuals that just need that little bit of interaction and assessment from our firefighters.